Made it. I'm Jalvan from the pathology department.
Next, Snehata.
Good evening, everyone. Myself, Dr. Snehata. I'm a second year resident.
We can
Also mentioned reminders.
Discussing this. So this for the next hour or so, maybe even less, and then feel free to stop me at any point in between, and we can chit chat a little more. But with that said, I'm no disclosures, and for the session, the first few minutes, I don't want you guys to take any notes here, right? Don't even worry about taking notes. I'm pretty sure this is recorded. You can always look at this later for things, right? So spleen is one strange organ where the pathologist needs to act like a clinician, right? You need to think like you're in internal medicine. You should not think like you're a pathologist just looking at the scope. That's a key part of the spleen, clinic lesions especially, right? So we will spend 5 minutes discussing some scenarios where you and I will have to think like an internal medicine resident or internal medicine faculty to see if the spleen could be blamed for anything, right? In any of these constellation of findings. And then I'll discuss 30 minutes or so of random entities that are typically seen in the spleen, splenic tumors, and different entities, stuff that you can learn from PATHOLGY and ChatGPT, right? You plug it in, you'll find it, the answer, right? You don't need to remember any of those 30 minutes from this presentation. And then towards the end, I like to deviate from my topic. I have a bit of an ADHD, so I go off topic and I'll randomly ask other things. But I want all of you to collectively think, and I'm not going to pinpoint one person and ask you to give me an answer, right? And of course, I will have a final question for this. They are 2s and 3s who have been through more pathology, what I like to call like a gold medal question. If you guys can collectively get the answer, you all get the prize. If not, I'll give you the answer and you will have learned something, right? This is what I'm going to do. So let's start with some scenarios, right? Let's see if we can think like an internal medicine resident. And there are 3 scenarios here, right? One to the left, 20-year-old male who had a recent fever, sore throat. The kid played football. I like to call them kids, they're still 20, right? And now the patient has abdominal pain, right? Okay, can any of you connect the dots and try to guess what all of this could be? And if there could be any involvement of the spleen in this scenario, that may or may not be an involvement, but if you can connect the dots and tell me a coherent answer to explain all of these symptoms, that'll be great. Any of you want to randomly guess what this could be?
So first would be infectious mononucleosis.
Okay, very good. And what would that do to the spleen?
So it will cause a splenomegaly, due to which the patient is suffering from abdominal pain.
Very good. Yeah. So this is the kind of reduction you need to do with scenarios. Okay, scenario number 2. 66 female with a 20-pound weight loss and bone pain. Can any of this connect with the spleen? It may or may not, right? But you have to think of the scenario and see if this could remotely connect in any way.
Multiple myeloma.
Okay, myeloma can explain these symptoms, but does any of this connect with the spleen?
Splenomegaly.
Myeloma doesn't cause splenomegaly, right? Normally, that's what it's strange for myeloma to do that. So this case was a point to show that there is no connection with the spleen here. Looking at the history, I don't see a reason to blame the spleen, right? So I just wanted to guess if there's any reason you could blame the spleen in the scenario. Okay, the third scenario: 55-year-old male, monocytopenia, lymphocytosis, and a BRAF mutation. Okay, I've given you a lot of history intros. Is there a diagnosis? Can it somehow involve the spleen? What are we talking here? It's a very classic mutation. Obviously, the moment I said mutation, it has to be a tumor, right? What are the tumors that you know that have a BRAF mutation? Name some tumors. Okay, hairy cell leukemia. Oh, there's a chat coming up. Wonderful. All of your pathway carcinoma, LCH. Wonderful. All of these have the same canonical BRAF mutation, right? Wonderful. In the name. And okay, does that connect to the spleen? Hairy cell leukemia? Does it do anything at all to the spleen? You can unmute and talk because it's my chat coming on the other end. Yes, Mandeep says yes, there's splenomegaly. Yes. So hairy cell leukemia doesn't involve the red pulp, there's splenomegaly, so it does involve things. So this is the kind of reductions you need to make and decide if spleen can be blamed for any reasons. And typically when the spleen is enlarged, there is sequestration, there's usually thrombocytopenia, and there's a reason for explaining counts. The counts can go low, right? So that's how you need to think in terms of scenarios. Okay, wonderful. I'm happy that all of you are involved. You're getting the answers correctly. So now we will delve into the next basic morphology portion of what you would expect to see in the spleen, right? The strange thing about spleen is it's a no man's land. Like when it comes to hematopathologist, they think sometimes that it belongs in surgical pathology, and when surgical pathologists see the spleen, they don't want anything to do with the spleen. They say it's a big lymph node. And I don't know, someone needs to mute yourself, maybe. Yeah. Okay. So it becomes a no man's land. But finally, most of the time, at least in the US, hematologists take care of any splenic pathology, right? And people don't go around biopsying the spleen, right? Nobody sticks a needle inside the spleen to make a diagnosis. So you need to indirectly input splenic pathology from the history or alternate sources, and we will discuss some of that. So let's start by discussing little of the growth, right? We will focus on some entities only here, not all of them. We will discuss lymphomas. We will discuss some of the vascular proliferations, which is more of surgical pathology. There are some vascular proliferations that are unique to spleen, and some that are very generic that you can see everywhere else, right? In all of the organs that you also happen to see in the spleen, right? So we won't discuss too much of that stuff. So typically, when you see a splenectomy specimen, the weight is critical, right? The weight itself tells you a lot, right? And always look at the capsule and make sure you've got thin sections because it just won't fix easily, right? And look at the cut surface and examination pattern, especially when there's amyloid involving the spleen. There's a very characteristic look to it when an amyloid involving the spleen. So it's always not a bad idea to look at for focal lesions and diffuse lesions. You can have 2 different kinds of things, right? Yeah, you can have Mets, but again, by the time they do a splenectomy for a Mets, it will be a very strange situation. They never do it because imaging is so good these days that they don't need to do a splenectomy to identify Mets. Right? Diffuse involvement in the red pulp, always take care, take a look. You won't see the white pulp that easily, right? That's important. I presume all of you have read about the histology of the spleen and the white pulp, the red pulp, the anatomy of the white and red pulp, right? And of course, if there's a miliary involvement, this is how a white pulp with a miliary involvement looks like, right? Then you know that there's clearly a white pulp enlargement, whether this is a lymphoma in the white pulp or whether this is something else altogether, you cannot say just looking at the growth. But it's good to identify miliary pattern versus the diffuse red pulp pattern on growth, right? And besides this, you also see nodular lesions, right? Sometimes in lymphomas, you can see nodular lesions, especially Hodgkin lymphoma can involve the spleen, and it's part of the staging, Hodgkin lymphoma, the classic Hodgkin lymphoma, and sometimes you will see lesions. In TB, you can see focal lesions too. So it's always good to note focal lesions. These might still be a big impact for all you know, right? It might be a viable lesion, it may not be a viable lesion, right? That's important to remember. And so the gross examination does give you a lot of information, even in a spleen, if you get a splenectomy, that is. But the key thing is, you don't normally get splenectomies, right? So it's not as important to know, but at least just for the record's sake, for your exam's sake, you're supposed to know all of these patterns, right? things that are very diffuse to the whole screen, and things that are focal or multifocal. It's good to remember like this and have your list. So diffuse list, you also have white pulp lesions and red pulp lesions, right? Think of it like this. Don't try to read each and every word on the slide here. It suffices to know that if you have a diffuse lesion, you have white pulp and red pulp patterns. And obviously, if it's a red pulp disease, you could have lymphomas involving the spleen. There are certain entities which we will discuss down the line. And you can have myeloid neoplasms, right? A patient could have a myelofibrosis, and there could be external hematopoiesis occurring in the spleen, and you will see a lot of myeloid cells, right? Sometimes myeloid cells are tricky, and it's very easy to miss things in the splenectomy. You might think it's, when I show you the pictures, it seems very easy, but in real life, I've had really senior pathologists just missing external hematopoiesis straight out because they just think that this patient was operated for some other reason. They just did a splenectomy and they treated it like gallbladder, right? Thinking like in 2 minutes, chronic inflammation, you're done. We have had T-cell lymphomas get missed in the spleen, right? Especially when it goes to surgical pathology. They're not thinking of these red pulp diseases. They can be insidious, they can be focal. It's very easy to miss and then go correct yourself later. That's the harder part. And of course, focal lesions we discussed. We will discuss some of these lymphomas and focal lesions down the line. I'll show you some pictures, so it should not be a hard thing. Right, we'll start with the lymphomas, right? Lymphoma can either be primary involvement or it can have secondary involvement, right? Literally any type of lymphoma can involve the spleen, right? And of course, if it occurs primarily in the spleen and nowhere else, then you call it as primary lymphoma in the spleen. There are very few lymphomas that are unique only to the spleen. One of this would be the splenic margin zone lymphoma, where the white pulp of the spleen shows margin zone lymphoma. And the second one important is the red pulp one, which is the hepatosplenic T-cell lymphoma, right? And these occur in very predictable age settings, right? Even without seeing the slide, if someone gave me the history, it's easy enough to identify these lymphomas. Anybody want to tell me what the history might be for a patient who has hepatosplenic T-cell lymphoma? Give me an age and a scenario. Let's see if we can get that typical scenario correct. What are the kind of patients who will get hepatosplenic T-cell lymphoma? What is the typical age group? Anybody knows? Okay, I didn't see the chat or anything, but okay. I will see. So yeah, hepatosplenic typically occurs in the younger patients, right? Usually 15, 20, 30, yeah, Neela, you said it correctly, younger age group, right? And it matters when it occurs in the younger age group, especially in the pediatric setting. The patients are young. The mothers and the physicians talking to the mother will be very concerned and worried. So especially if it's hepatosplenic, it's aggressive, right? And you need to be very sure before you raise the possibility. So obviously they're not going to stick a needle in the spleen for you to diagnose hepatosplenic T-cell lymphoma. So you're going to have to use some other clues to get to the diagnosis, which we will discuss in the coming slides, right? So that way you discuss things. Let's start with splenic margin zone lymphoma. And like I told you, on gross examination, you will see these multiple miliary nodules, which kind of look whitish, which is because of expansion of the white pulp. So typically margin zone lymphoma will involve the white pulp, and it behaves properly and follows this histoanatomy of the spleen correctly. It looks like a caricature of the white pulp, but thankfully, splenic margin zone lymphoma will show involvement in either in the peripheral blood, the cells will come out and they'll circulate in the peripheral blood, or they will go to the bone marrow and they'll sit there. So that's why to diagnose splenic margin zone lymphoma, we either do a flow of the peripheral blood, or we will do a bone marrow biopsy and look at the bone marrow biopsy. These are the two ways you can get to the diagnosis. And you can make a presumptive diagnosis. Usually when they raise this possibility, I will typically ask if there is splenomegaly. I will ask if there's lymphadenopathy by CT. Sometimes they're not even done a CT scan, and typically the CT scan will not show lymph node enlargement, but only isolated splenic enlargement and pancytopenia. So once you see the combination of a CT without lymphadenopathy, isolated splenomegaly with some pancytopenia, there may or may not be cytopenias. But you have to start by seeing a peripheral blood smear, right? Look at it, and sometimes you can make the call. If the counts are high enough, it's easy. And if the counts are not super high, it's not a bad idea to run a flow to test the B and T cells, right? And I've shown you a picture at the bottom on the right side, the peripheral blood showing circulating splenic margin zone lymphoma cells. They don't have any characteristic morphology that the moment you look at it, you can say, aha, this is my SMCL. There's very few things that you can look at the peripheral blood and have an aha moment. Only one of them is hairy cell leukemia, right? If you see the classic pictures of fuzzy cytoplasm in the peripheral blood, you may be able to diagnose hairy cell leukemia. But hairy cell leukemia is also not easy because it will present with pancytopenia and the number of circulating cells will be quite few in the peripheral blood. So it's very easy to even miss hairy cell leukemia on a peripheral smear if we do not have a flow, right? So, but most splenic margin zone lymphoma, the counts are usually normal or high. So the circulating cells are usually easy to see in the blood, right? If it's too easy to see, I would not even think of hairy cell leukemia typically because it usually doesn't present with high counts, right? That's an important thing. But now we're talking about margin zone lymphoma. So look at that picture. And on the right side, there's a bone marrow biopsy because the bone marrow biopsy is much easier for people to do rather than a splenic biopsy. So they go poke the bone marrow biopsy and you find some infiltrates, right? Those they don't look paratrabecular and they don't look entirely sinusoidal either. They look interstitial. So these are the patterns you look for. Is it paratrabecular? Is it interstitial in the marrow? And if it's interstitial, is it also sinusoidal, right? Especially only inside the sinusoids. And is it exclusively sinusoidal? That's also important to know, right? So we make these deductions based on what we see. Now, this is some classic textbook pictures of how the patterns look in splenic margin zone lymphoma if they end up doing a splenectomy. Sometimes for severe thrombocytopenia occurring in the setting of splenic margin zone lymphoma, they might end up doing a therapeutic splenectomy to get the splenic counts, the platelet counts back, right? It's more therapeutic to prevent the sequestration. And it's partly therapeutic for the lymphoma too, if you get the spleen out, which they sometimes do, right? And this is a typical white pulp expanded pattern where the whole white pulp looks monotonous and monophasic pattern. Or you might see this pattern on the right, which is called the triphasic pattern, where you see the germinal center, the mantle, and the expanded peripheral monocytoid B cell zone, which is the lymphoma portion. And of course, if you do a CD20, all of this will light up, right? And you might also see some staining in the red pulp here and there, but much of the CD20 immunostaining will be restricted to the white pulp. And of course, you could ask me, how do you look at the picture on the right and tell me that this is lymphoma, right? If I just show you that in isolation, you would say that that's probably just marginal zone hyperplasia occurring in the spleen. How do you get to lymphoma, right? But your clue will be the weight of that spleen. Now I'll tell you that the weight of that spleen on the right side was 1 kilogram, right? So obviously you have to connect the dots. No normal person can have a 1 kilogram spleen. And of course, I have a scrape of the spleen and I have evidence for a clonal B cell component in that spleen. So of course, I also know the diagnosis, right? But just looking at the morphology, you don't get to diagnosis. You unfortunately have to connect all the pieces of clinical information, the flow, the morphology, the weight of the spleen. And if there was a bone marrow biopsy, check how it looked when you do the CD20 IHC. Right? Then this is how it looks. This is actually a lymph node on the left side that I'm showing, where margin zone lymphoma occurs in the paracortex, right? In the lymph node. Typically, it occurs in the margin zone and it expands and goes to the paracortex. And it fills the paracortical lesions with B cells. So that's how you know that the lymph node is abnormal. If there's too many paracortical B cells, usually the first inference is a margin zone lymphoma. And if the reactive follicles are seen, you blame margin zone lymphoma as a possibility. Sometimes margin zone lymphoma can grow inward into the follicle itself and colonize the follicles. So what I'm showing on the left is follicle colonization in the lymph node, and the middle picture with all these bunch of arrows is showing more of a germinal center colonization. I'm not going to say that the picture is easy to understand, but those are all cells showing follicle colonization. Some of the FDCs are being marked over there in the follicles. And of course, you need to learn how to identify FDCs in the lymph node germinal center. They are typically doublet cells where two nuclei kind of touch each other, what we call as kissing cells. They're very easy to identify in the lymph node on H&E. And it's important for you to know how to distinguish and identify an FDC because that becomes important in the context of follicular lymphoma grading. So as to not to mistake FDCs to be centroblasts. Otherwise, you'll be constantly overgrading your follicular lymphomas. But that's besides the point of the spleen lecture. And on the right side on the top, you can see the red pulp with a lot of diffuse lymphoid involvement. So you can have red pulp involvement too in marginal zone lymphoma. So don't just bank on all the cells being the white pulp before you make a diagnosis, right? Thankfully, we don't have to look at a screen to make a diagnosis of a marginal zone lymphoma. We look at a peripheral blood, we look at a marrow, we can make inference. That's easy, right? And it's always inferential. And the bottom right, you have a lot of CD20 positive cells looking like glioblastoma files, right? They look like files of an Indian file pattern. When CD20 looks like this, you immediately think of a marginal zone lymphoma with sinusoidal involvement. So patterns. That helps a lot in these diseases. We don't need to use any fancy stains. Between 5 stains, you have 90% of all lymphomas can be diagnosed, right? I know I'm showing you a slew of stains that comes in the WHO book, but looking at the immunophenotype, the only useful stain here is probably CD20, right? And all the other stains are pretty much useless. 5 and 10 and all of these stains, people will diligently do all of these stains to exclude mantle cell lymphoma, follicular lymphoma, but morphology is key. If you have a sinusoidal pattern exclusively in the bone marrow, you're probably dealing with the marginal zone lymphoma. It's very unlikely to be a follicular lymphoma. You will never have mantle cell lymphoma ever coming in the bone marrow biopsy. Mind you, I'm talking about immunophenotype on the bone marrow biopsy because I'm not biopsying the spleen here, right? And mantle cell lymphoma is very hard to diagnose in a bone marrow biopsy. You always do it only in the right context. Primary presentation in the bone marrow will be very, very unusual, right? Most of the patients usually have nodal mantle cell lymphoma before you even get to a bone marrow biopsy, and most of the times it's changing. Marginal zone lymphoma, especially splenic marginal zone, is often the only lymphoma where you do the bone marrow biopsy for primary diagnosis to explain things. So CD20 is the main take-home point. 5 and 10, people will do diligently to exclude CLL and mantle and follicular, but honestly, I won't do it if I'm certain of the clinical context. Cyclin D1, people will diligently do it, and I don't typically do cyclin D1 in patients who don't have a known diagnosis of mantle cell lymphomas, right? Okay, let me throw a trivia question. What cells in a normal marrow will express cyclin D1? What would be internal control? Anybody? You have to know your internal control for every stain in heme, right? Like the back of your palm, you need to know it because many stains won't work, right? And when it doesn't work, you have to know when it doesn't work. Just seeing external positive control is not sufficient. Anybody want to venture what cells will express cyclin D1 in a normal marrow? Endothelial cells, and that is correct. Okay, one more. Anybody? This is actually an interesting question and offers a segue into histiocyte lesions. The second cell is the histiocyte, right? So normal histiocytes do use a lot of the MAP kinase pathway for their signaling. And cyclin D1 expression is usually a rough surrogate of an overactive or an active MAP kinase signaling pathway. So that's why if you look at the histiocytes in a marrow, plasma cell, you know what plasma cell, normal plasma cells, no, they don't stain. But there's a class of myelomas where you have rearrangements involving cyclin D1 that will stain for cyclin D1, right? But normal plasma cells should not be staining for cyclin D1. But plasma cells do non-specifically absorb cyclin D1 all the time. So you have to know that plasma cells are famous for absorbing random things. You never believe the plasma cells staining if you don't have to, right? So remember, histiocytes, MAP kinase, cyclin D1, right? That's why anything with a B RAF mutation usually also shows some cyclin D1. For example, hairy cell leukemia will also be cyclin D1 IC positive. So if you ever do, next time you see a hairy cell in the bone marrow, do a cyclin D1, you will see that it's weakly positive. Same thing with PTC or papillary carcinoma. Try doing a cyclin D1 when there's a B RAF mutation, it'll be positive. So it's almost like a poor man's B RAF, right? If you don't have a B RAF at your institution, do a cyclin D1. So it can sometimes explain if there's a canonical B RAF there. Okay, enough of the IC talk. And there's a little genetics I wrote on the right side, but most of those are used as genetics. It's all listed in rare sets of reports, but I don't think it has much use. And there's really no use for karyotype in a bone marrow biopsy to diagnose marginal zone lymphoma. And of course, there are some new fancier markers like IRTA1 and TBET, but nobody does this routinely, and half the time it doesn't even work. So forget those. And of course, there's more genetics at the bottom right that I've written, but those are all from WHO, but not at all relevant for diagnosis, right? Only CD20 right there, and that's all you need to make a diagnosis. And if you have a flow, you can make the call. But if you just have a biopsy and a sinusoidal 20 pattern, you pretty much have a diagnosis. And of course, what are the mimics? Marginal zone hypoplasia can do that. That looks exactly like the lymphoma I showed you earlier. It's a marginal zone hypoplasia. And again, you have to use context, right? And they look very similar to lymphoma. So you have to be very careful about not calling marginal zone hypoplasia as lymphoma. Sometimes you will see a normal spleen come out in a trauma case, right? They will just remove the spleen in a gunshot wound or whatever it is, and they will send you the spleen for examination. And you will see this kind of prominent marginal zone sometimes, and you should not jump to the conclusion that this is lymphoma, right? It's perfectly the weight is normal, and you just see some expanded marginal zones, leave it as hypoplasia. Don't really jump to lymphoma there. You don't need to flow the spleen and try to get to diagnosis either, right? And of course, there are other splenic lymphomas, small lymphomas that can involve the spleen, right? The low-grade lymphomas like LPL, follicular, mantle, CLL, all of these can involve. But in most of these patients, it's very unlikely that you'll make a primary diagnosis in the spleen. They all will have nodal disease typically, especially follicular, mantle, and CLL. They either have peripheral blood or nodal involvement, where you have proven the disease with flow or morphology, and then you get to a splenic diagnosis. LPL being diagnosed in the spleen, I've never heard. It's a differential, yes, but nobody ever makes a diagnosis of LPL in the spleen, right? You never have to get to a splenectomy. You do a CL paraprotein, and what paraprotein you get in LPL? Mostly, what heavy chain? IgM, right? Yeah. So IgM, wonderful. Thanks, Dr. Paul. So IgM paraprotein, IgM is pentameric, so it increases the viscosity, and then you start feeling dizzy because of our wonderful IgM, right? So that's also wonderful lymphoma to learn clinical constellation, right? Let's say I have to give you a history of a patient who has cerebral obtundation and glomerulonephritis, right? You have to connect the dots to see what's happening. If a lymphoma could explain cerebral obtundation and immune complex glomerulonephritis, the one answer would be a lymphoplasmatic lymphoma producing a cold or a globulin, right? It does all those kinds of things, so that can explain things. So it's good to know what all clinical manifestations you can get because of lymphomas, and then try to connect the dots from a clinical perspective. Especially the low-grade ones, it's good to know the clinical perspective and the therapies, at least the basic frontline therapies, you should all be aware. I'm showing you something on the right. Now I'm looking at that picture. Can I really make a guess what this could be? Could it be any one of these alternate lymphomas? Yeah, it could be, but I cannot make a call. But what I can tell you is there's a lot of red pulp involvement by something over there that kind of catches my eye. That's about the only thing I can say. And the only thing I can say looking at the white pulp is it looks like the tripartite distinction is dissolved. So this could be anything. Right? It could be follicular lymphoma. It could could even be a CLL for that matter, but CLL presenting primary nodule in the white pulpy part, it could still be a marginal zone lymphoma. That would be my differential there. This is to show you at high power what are the cells, the centrocytes, and the T cells, but morphology will only go so far. So you cannot go too far with morphology in the low-grade lymphomas, right? This turned out to be follicular lymphoma on the screen, right? So indistinct follicles, it turns out to be follicular. Hopefully you will have 10 and BCL2 if it's a low-grade follicular lymphoma. If it's a high-grade follicular lymphoma, your 10 might be negative, your BCL2 might be negative, and then again you'll be stuck, right? Then you have to get back to your morphology of nodal lymphoma. This is one more here, and this is one more here. So obviously, looking at these pictures, they all look the same. You'll never be able to get to a diagnosis. You'll need a combination of stains in history to get diagnosis. This turned out to be mantle cell lymphoma, and obviously, mantle cell cells are look centrocytic. They look exactly like follicular lymphoma sometimes. You cannot make the distinction just looking at the H. So use stains if you have to. And obviously, that patient had known lymphoma there. So it was not a huge diagnostic confusion trying to get to mantle cell lymphoma. And of course, let's move on from the white pulp lymphomas, which is the martle cell lymphomas, and to the red pulps. So obviously, the only important red pulp one is hairy cell leukemia, right? That's the only thing that you need to remember. And most of the time, you can get the answer by doing the peripheral blood flow, NGS, or a bone marrow biopsy and bone marrow flow. Pretty much these 4 specimens and answering test will get you to diagnose of hairy cell leukemia. But what is the challenge with hairy cell? Is to be able to think hairy cell, right? As a possibility when you're seeing the clinical scenario. That's the biggest challenge for why people miss hairy cell leukemia. Even when they're seeing a pathologist, they easily miss it. 2 or 3 biopsies will go, they'll call it normal, until a 4th person will catch it, right? And then you won't feel so good when somebody else finds the diagnosis and you forgot to get the diagnosis. So this hairy cell, this is a textbook picture. They will always ask you this in the exams. It's good to know the basics. So looking at the left, it involves red pulp. It causes what we call as blood lakes, right? There's a lot of on gross examination, and it's mainly in the red pulp. And if you do IHCs, the useful IHC again, I will say, is not all these necessarily the big list, but rather very few like CD20, start with 20, do a cyclin D1, right? And annexin also people usually don't have frequently, but 25 is probably important, so do a 25, right? Or send your 25 out if you don't have 25 in house. It's good to send out 25. All the other stains are kind of just a cherry on the cake, right? Annexin A1 is supposed to be good, but it's not an easy stain to get to work. And all the other stains are kind of, you tend to do flow more often for hairy cell, so it's not like you have to do a ton of IHCs to get to the diagnosis. You will need IHCs only when it's a dry tap and you don't have a sample for flow. These days we have 10 color flow and we have hairy cell panels that pretty much interrogates all the key markers, right? So you are not reliant on flow. The biggest bang for the buck is 20 cyclin D1. You could do a 5 just to exclude a mantle cell lymphoma. In mantle cell lymphoma, you will have a bright cyclin D1 in the lymphoma, whereas in hairy cell, you will see kind of a weak cyclin D1. So just looking at the cyclin D1 pattern, I can tell you this is hairy cell. And of course, the HNE is very characteristic. In a bone marrow biopsy, the one good look at the HNE and you can say most of the time, right? On the bottom left, you can see how a hairy cell will look. It will just look like a damaged marrow, and there's these